So a nice warm welcome to everyone. Thank you so much for joining us today at the Community Engagement Series. My name is Priscilla Medeiros. I'm the Knowledge Mobilization and Community Engagement Specialist at the Edwin S.H. Leong Center for Healthy Children. I also moderate this particular series. I'm incredibly excited to introduce both of our speakers for today's session. We're joined by Maureen Smith, who's a committed patient partner who thrives on collaboration with research teams in Canada and internationally to co-design research studies and programs that embed and value the expertise of people with lived experience. Her involvement stems from a childhood rare disease diagnosis, an ensuing healthcare journey, and her passion for teaching. Maureen co-leads Inform Rare's patient engagement and has the privilege of learning from extraordinary patient and youth partners. Our second speaker joining us is Beth Potter, who's a professor of epidemiology and public health at the University of Ottawa, where she holds the University Research Chair in Health Services for Children with Rare Diseases. Her research aims to produce evidence to improve healthcare and outcomes for children with rare genetic diseases. And she's the principal investigator for the Inform Rare Research Network, where she co-leads the patient engagement strategy. So today's presentation will explore lessons learned from a mixed methods study that evaluated patient engagement in the Inform Rare Pediatric Rare Disease Research Network, focusing on how the evaluation was co-designed and the methods used to go beyond process evaluation. So welcome, Maureen and Beth, and I'll pass it over now for you to start your presentation.
Okay.
Thank you so much, Priscilla. So welcome, everyone. Nice to see you. Looking forward to the presentation and also to all of your questions and the question and answer period. And as Priscilla explained, I'm a patient partner, and we're really looking forward to talking to you a bit about our patient engagement evaluation. And over to you, Beth. Do you want to just say hello and keep going?
Hi, everyone. Great to be here. Can you hear? Oh, I just froze, I think, for a second. Hopefully that's the only time. Just wanted to briefly review the objectives for the session. So we hope that you will learn about how a rare disease research network, Inform Rare, approached evaluating our patient engagement in research strategy and some of the methodological considerations that we faced. We'll discuss the steps to co-design a mixed method study to evaluate patient engagement in research, including some of the unexpected insights that we gained from this approach. And then the third objective there is really to provide a reality check on some of the complexities of conducting a robust evaluation that will guide and improve patient engagement while actually also continuing to deliver high quality patient engagement and just what that's for us. So back over to you, Maureen.
So I'm taking my prerogative as co-presenter to share this slide for you. I always like to show it. It's when a picture paints 1,000 words. So no need to say anything more about it than just enjoy the little take on why we do patient engagement. And moving along. Okay, so right from the beginning of the project, evaluating our patient engagement was really important to us. And Beth and I had collaborated on an earlier project, and we kind of did the evaluation as an afterthought. And I remember us saying, yeah, we didn't do a great job in evaluation. If we do another project, let's build it in. So that's how we it was right from the grant stage. And we wove it in through the entire project just because we thought it was really important. So next slide. So just a last one on a little bit about the theory and the importance of patient engagement evaluation. And if you look at it from the perspective of different interest holders, and this is adapted from Julie Abelson's slide, it's a really interesting way to look at it. So like the funders and the sponsors, it's all about the investment. Are we getting a return? Are we achieving our goals? The scientific community is interested in what works, what context and what outcomes. What are the effects of the impacts? The impacts is much more important now than it was when we first started. The practice community is saying, well, how well are we doing? How can we do better? for us, like as patients, families, and caregivers and communities, like, well, what purpose is my engagement serving? I entered this world about 26 years ago, and I think, I could have gone another route. Like maybe I would be knitting socks or something. So, what is the impact of my contributions, and is it a good use of my time? And finally, we still have the skeptics out there who are saying, well, show me it works, because I really don't want to do this. So I really like kind of framing it from the different interest holders. Okay, I'm going to hand it back over to Beth.
Great, thanks, Maureen. Really brief overview of Inform Rare. Our research network includes more than 65 investigators. So we're a large network co-designed by patients and families, healthcare providers, policymakers, ethicists, and methodologists. Inform Rare was established in 2020 with funding from a CIHR Innovative Clinical Trials multi-year grant. And so, as mentioned earlier, I'm a PI for Inform Rare. And importantly, Maureen is a patient partner co-principal investigator leading our patient engagement activities. So the goal of the overall network is to generate evidence to support decision-making about care for rare pediatric diseases. And our focus is on 3 specific diagnoses, which we won't talk about any further today, but these are mucopolysaccharidosis, so MPS, phenylketonuria, PKU, and spinal muscular atrophy, or SMA. And we have a website with lots more information about what we've been up to. And I think it's back over to you, Maureen.
Okay, so this is kind of how we're set up. I won't spend a lot of time on this, but just to give you an idea. So we've got the research team. We've got a patient partner co-principal investigator, which when we started years ago, it was very rare to have someone, patient partner, be a co-principal investigator. I think Beth was taking a risk there. So that's me. And then we've got 6 patient partners who are co-investigators, so 2 representing each of those 3 diseases. Once we got started and get going, we set up a parent advisory group, so another level of involvement, a youth advisory group, and we have one special advisor who didn't fit into either category, but was someone who was really keen to be involved and who's provided lots of great insights. So that's how we're basically set up. And so you can see there's quite a few people involved, right? And then so this shows you a little bit of how the levels of involvement are. And the reason why the line on the 2 bottom lines are so long is because we're flexible. So for example, in the registries part of the work, the patient group leaders who are co-PIs actually lead that piece. I just step back and kind of observe and keep updated on what's happening, but they're really the ones who are able to do that. So it's dependent on the specific project that the network is doing. Right now, we have our parent youth advisors leading a project. And that's it took a little while before we could get to that stage, but we're actually doing that. So you can see that it's kind of flexible, and it really depends on what the specific activity is. Okay, next slide. All right, so I'm not going to read all of these. I'm just want to give you an example of the activities so that you know what we're actually kind of evaluating that we do with our patient engagement activities, and just also to really stress that it started at the grant application time. I remember it was summertime. We were writing it, and we actually, really worked as a team with patient partners to do the grant application and select some of the outcomes to the trials that were being proposed in that. And there was a lot of changes made at that point because of that. So it goes all the way through, and there's lots of activities. So we're not evaluating one specific thing, we're evaluating a set of different activities. Next slide. And basically, because our patient engagement strategy was co-designed, our goal was to do the same for the evaluation piece. It just wouldn't make sense to not continue in that way. So we created a small steering committee to lead the development of the evaluation plans. And that was interest holder. So that was Beth and a postdoc and our research project coordinator and me as the patient person. And then from there, we then created an evaluation committee, which again was multi-interest holder, a much bigger committee to seek broader feedback and to get them involved. So we do consider that it really is co-designed. Okay. And we chose the Engagement Impact Toolkit for a couple of reasons. And this is the one that's designed by Julia Abelson's team at the McMaster University. So I had actually been involved with its development for the Ontario Health teams as one of the people on the as a co-investigator. And all the way through the development of it, I kept thinking, whoa, we could use this. We could adapt this to our own needs. So there was a little bit of familiarity with the toolkit. The most important thing to me was that the toolkit was co-designed, and I was there with the other patient partners, so I know it was co-designed, and that to me is always important. So I'm taking something that's already been vetted and has already gone through a whole layer of perspectives. So we took the toolkit and then we adapted it for our network's purposes. Oh, that's there. And back over to Beth.
Great, thanks, Maureen. So the first module in the toolkit is planning. And so here it's about kind of outlining like really what is it that we're planning to evaluate and what are our goals with our evaluation. And so we wanted to evaluate Inform Rare's patient engagement activities quite broadly. And we have a lot of different projects on the go, and evaluation or the patient engagement is different across different projects, but we wanted to kind of be all encompassing. And then we also wanted to focus initially, and this changed over time, as you'll see, but on one specific project. So we had developed a core outcome set for one of the three conditions that Inform Rare focuses on, mucopolysaccharidosis, and that had had a lot of patient engagement over the past year. So we thought we would also maybe have a focus on one specific project. The initial goals of our evaluation were to assess our accountability. We wanted to assess satisfaction with the patient engagement strategy from the perspective of all network members, so patients and caregivers, as well as other network members. We wanted to gain insights that would help us to improve our engagement practices. So we purposefully designed this evaluation around the midpoint of our kind of initial multi-year funding. And we wanted to understand, of course, the impact of patient engagement on all network members, as well as our research processes and our outputs. And we wanted to contribute to the science of patient engagement evaluation. So Maureen already talked about our steering committee. And so the steering committee, this core group of 4 of us, really took it upon ourselves to really understand the Engage with Impact Toolkit, the modules, what was involved. And we would kind of initially, we met quite frequently, and we were starting to kind of adapt the modules to the specific needs of our network and our research. And I think that's another really nice thing that we were talking to you, Priscilla, about before the meeting, that the Engage with Impact team is also really welcoming of people adapting the toolkit for their own kind of research purposes. And we're very supportive and helpful. We had a lot of questions for them as we were kind of planning this. And then we would take drafts out to the larger evaluation committee, which included a larger group of patient partners and advisors, as well as some additional researchers, clinicians, and the research staff member to kind of work together to sort of make sure that we were focused on the questions and goals that were important to everyone. So I'm going to go through this timeline slide really quickly. And the main message of the timeline is that the timeline was not at the end what the timeline was we thought would be at the beginning. So we thought that this would take about a year, which was really ambitious. So we had the steering committee, the sort of evaluation proposal, adapting the toolkit, convening the evaluation committee, working with them. You can see now we're already, like, time is already ticking along here, right? So then we had we used a mixed methods evaluation approach with both surveys and qualitative focus groups and interviews, which we'll talk a little bit about later. that, look at that, how long that's taking now. We're getting into the analysis, we had a document review. And so it took more than twice as long as we originally anticipated that it would, and left us, I think we still sort of have this question. I think we feel like this was a really good investment of our time and energy, but it also makes it challenging to balance actually doing engagement activities with co-designing and evaluating the engagement. So the second module in the toolkit is tailoring. And so this is where you really start to think, okay, what is it that we're evaluating? What is Inform Rare's patient engagement activities? What is our strategy? And so here we outlined as inputs our patient engagement guiding principles, which we co-developed with patient partners and advisors. Those are on our website. Our staff resources, our budget for patient engagement. We looked at our patient engagement activities. So Maureen showed some of those on a previous slide, and we recognize that these are really role dependent and project dependent. So this is the complexity of evaluating patient engagement in a research network, is that you're dealing with a lot of variability. The methods of our patient engagement. So we talked about, well, we have virtual meetings, in-person meetings, there's communications, there's review of documents, like what are we really doing with patient engagement? And that helped us really understand what are the anticipated outputs. So what kinds of things could we look at? We could look at the numbers of people contributing to different activities. We could look at changes that we've made to our projects, our materials. We could look at the impacts on people in terms of knowledge and skills. And then we look at sort of the bigger picture impacts. And because we were doing this kind of midway through our grant funding, we looked mainly at short-term and medium-term impacts. And we were interested in the impact of patient engagement for people in Inform Rare, the projects, and the network as a whole. Around this time of the planning of the patient engagement evaluation, we decided to conduct a separate evaluation for the youth that would really that would not adhere to kind of all the modules in the toolkit, partly because the Engage with Impact toolkit was not co-developed with youth or with youth in mind. And so we actually developed a separate youth engagement evaluation, although as you'll see, in some of our selected results that we're going to show you, we were able to kind of pull everything back together at the kind of analysis and results stage, which was really exciting. So we co-developed with 3 members of our youth advisory group a separate project for the youth evaluation, where we worked with them to select evaluation domains based on their priorities and these questions. So preparation and support. Has Inform Rare provided support that enabled youth to participate? Knowledge and skills. Have youth gained new knowledge and skills as a result of their involvement with Inform Rare? And youth researcher partnership. So does youth engagement have an impact on Inform Rare's work? They really wanted to know, are we making a difference? So back to the kind of adult evaluation and Engage with Impact toolkit. These are the 8 domains that are part of the Engage with Impact toolkit. And I think most people who use the toolkit probably, and we did this as well, select specific domains to focus their project on. And so, Maureen, were you going to maybe talk about this slide where we selected specific domains from the toolkit?
Oh, you're doing such a great job. Keep going.
Okay, so we decided to select 4 existing domains from the toolkit: knowledge and skills, priorities and decisions, equity and inclusivity, and culture change. And then even though Engaged with Impact is really focused on impacts of patient engagement, we also, especially because we were partway along our sort of with our kind of in the midpoint of our funding, and we wanted to be able to gain insights that would allow us to change our practices kind of in real time. Well, not really real time because it took us so long, I guess, but to be able to sort of get some process information. And so we actually took the confidence and trust domain and the patient outcomes and experience domain from the toolkit and merged them into a combined domain that we called satisfaction and engagement experience. that was really about patients and patient partners and advisors' experiences, and actually non-patient investigators as well, experiences with our patient engagement activities. So then the next module in the Engage with Impact Toolkit is selecting items. So once you've selected your domain, so we have these 5 domains you can see in the left-hand column. If you go to the Engage with Impact website for their toolkit, there are lots of items associated with each domain, and you can think about your evaluation goals and select items that really most closely align with your activities and with the goals of your evaluation. And this was actually extremely helpful in the toolkit to be able to now get down to, okay, what do we really, within knowledge and skills, like what would tell us that our patient engagement strategy is going well? And so you can see here, I'm not going to read all of these. Maybe I'll actually just pause for a moment and let people read through a couple of them just so you can kind of get the gist. And so what you can see here, I think, is that we're really looking at our patient engagement strategy from the perspectives of everyone in the network. So patients, partners, and advisors, as well as other research team members and the whole network.
I have a quick little anecdote about that one, Beth. So if you look at the second one, satisfaction and engagement experience, and you look at the description in the first box, in the toolkit, it's written as satisfaction with patient engagement methods and activities. And we heard from our patient partners, satisfaction and or dissatisfaction. So it's just a little adaptation that people thought, yeah, it's nice to identify that maybe it's not satisfaction, maybe it's dissatisfaction. So that's just what you get when you're co-developing, and you get different perspectives on wording, which can be important to people. So I thought that was an interesting anecdote. Back to you, Beth.
Okay, so the next stage is collecting. So collecting the actual data to support the evaluation. And so we actually chose a mixed methods approach to our patient engagement evaluation. So we collected information really from 3 sources, quantitative data from questionnaires and from a document review, and then qualitative data from semi-structured interviews and focus groups. So with respect to the questionnaires, we adapted the Public and Patient Engagement Evaluation Tool, or PEAT questionnaires, which were also developed by Julia Abelson and her team. So really the same team at McMaster University. So we used the PEAT Module B for the adult patient partners and advisors, and the organization questionnaire for the survey of non-patient investigators and staff. We developed with the Youth Evaluation Committee for the youth patient partners, and the surveys were available online in English and French, and we analyzed them descriptively. This mixed method study was what we call sometimes in mixed methods research an explanatory sequential design, which is really where you kind of start with some just usually descriptive quantitative data. So in this case, the surveys. And then the purpose of the qualitative data is really to get a deeper understanding of and more insight into what's going on. And so we used semi-structured interviews and focus groups. We invited everyone, so all of the patient partners, as well as non-patient investigators and staff, to participate in a semi-structured interview or focus group. There was a lot of overlap almost complete overlap really, between people who completed the survey and the qualitative part, but they didn't have to have completed the survey to do the qualitative part. And we gave people the option of either a one-on-one interview or taking part in a focus group. And the focus groups were kind of within role groups. So we did separate focus groups, for example, with investigators and staff, with adult patient partners and advisors, and with youth advisors. The interview guide, we mapped some of the questions to the domains from the Engage with Impact Toolkit and expanded on some of the questions that were in the questionnaire. Maureen and I conducted the interviews, and we'll talk about the implications of that later. And then Maureen and I and Allison, our research coordinator, the three of us co-analyzed all of the qualitative data, which took an enormous amount of time, but was so interesting and really rewarding. And we used a method of analysis called framework analysis. And then we're not going to really talk about the document review this afternoon, but we also, along the way with Inform Rare, on a monthly basis, we actually just document all of our patient engagement activities. So if we have a meeting, what was the topic, who was there, how many people came, what changes were made as a result, what feedback did we receive, what feedback did we give back afterwards, and so on. So we kind of have a kind of spreadsheet of information that we also use to just kind of put the rest of the evaluation in context. And so then the final stage is refining. And so we're going to show you just some selected results from the mixed methods evaluation. I think just a couple things to note, and then I'll turn things over to Maureen. So we had really high response rates to the surveys particularly for the youth advisors, everyone participated, and the adult patient partners, slightly lower for non-patient network members, so investigators and staff. And then we also did quite a number. I think we had in total about 11 different interviews and focus groups. So it was a mix of different one-on-one interviews and focus groups. But we had 5 youth advisors, 8 adult patient partners, and 14 non-patient network members take part in an interview or a focus group. So we had also quite a lot of qualitative data. And what we were able to do in putting the findings together was actually take the youth domains and the adult domains and kind of integrate them together because the findings were really quite similar. And so you'll see that in the results. So I'll turn things over to Maureen to talk about what we found.
Right. So we've got 5 slides on the results. It's not the focus of our presentation today, but it's kind of like going to a cooking class and they show you how to cook something, and what if they didn't let you taste it at the end? that would be pretty bad. So we're just going to look at them really quickly, just out of curiosity, if you want to see what came up. So this one is about the adult patient partners satisfied with their experience and appreciate our flexible approach, and the one about the youth advisors. So I'm just going to be quiet and let you read the quotes because I think that's where the richness is. So I'll pause for a few seconds and let you read what they actually said. So just to address the first quote was very meaningful to me as a patient partner because basically, without disclosing too much, the message was that I am able to interact and to be part of this because of the flexibility. And I've always resisted any other offers to be involved as a patient partner because I worried about not being able to commit because of my health, which can radically change from one month to the next. A lot of these people who we're dealing with have repeated surgeries, for example. That piece was really important to me, that we're actually silencing people who we need to hear from because our engagement practices are not flexible enough. And then, of course, we've all been youth, and to know that you're actually communicating with people who understand how your life, I thought was really meaningful. So that was some of the interesting findings. Next slide. Right. So this one's all about, so what? Is there an impact? And that was a real eye opener for us because they were confident that the contributions are incorporated, but they really struggled to identify examples. And we thought we were doing a good job on that. We thought we were really producing these what we heard, what we did documents for everything that we were doing. But maybe what we did still not precise enough to know that there actually was some change. So I'll pause again and I'll let you read the quotes on that one. So that third quote from a non-patient network member is really important to us too, because what we found out is that the outcome was actually changed for the clinical trial based on what they had heard from the youth advisors. So that's pretty powerful that the impact was actually changing an outcome. So and we think that without doing that focus group, we would not have necessarily known that. So that kind of detail. So next slide. Yes. So we were talking about like reciprocity, right? Like, are you giving back? Are people developing some skills, and how important is that to them? So these pieces of the evaluation kind of deal with that. And once again, I'll pause so you can read. Okay. So again, one of the things that we heard consistently from our non-patient partners was that, we want to know what's happening too. Like if we have a meeting with them, we'd like to share, and what impact did it have, or things like that. So and we're sometimes researchers worry about, we're giving too much information, we're gonna bog people down, they've got other projects to do, and people basically said, look, we can decide on our own to read it or not. So it's like, just give it to us, and if I don't want to read it, I won't. But if I have the option of reading it, then that's better for me. So that was the communication piece, was kind of interesting, and about that knowledge and skills kind of tied into that. Okay, second to last one. Right. Okay, so once again, I'll pause so you can read. Yes, that was some of the most insightful. One of the most insightful findings that we had was someone said, "What about the questions you don't ask us?" And I was like, "Oh, we had a lot of discussion about that, right?" And also the having a liaison, which seemed to be like much appreciable. We'll talk a little bit about that when we get to how we made the decision to actually conduct the interviews ourselves, which was something that we debated for a long, long time. Okay, last result slide.
Oh, can I just add one more thing that
Oh, yes.
because I think it was tricky to select quotes for this, and I definitely agree. I mean, I love actually that one of the youth said, "What about offering areas for improvement do we think they need improvements?" Which is just great. Anyway, but another non-patient network member, also, I think, just wanted to mention this, Maureen, because I think we found this really meaningful. Also talked about actually, I think more than one person talked about the impacts of patient engagement and interacting with the patient partners and advisors, and the impact that it had on their patient care. And so we're also trying to think about, like, what are some of the sort of broader impacts even beyond our own research is thinking about this. And so that was another piece that I think was surprising. This was kind of probably the domain, do you think, Maureen, where this was where kind of more surprising
Yeah.
insights, right?
Yeah. I'm glad you mentioned that, Beth, because if you say to me, what's the most important part of that project that you recall, it was those conversations, because I was that youth sitting in that waiting room and basically said, when I go into the waiting room, when I go into the examining room, and I'm with that youth, I'm approaching that youth in a different way. I'm asking different questions, and I'm interacting differently because of what I've learned, what's important to them, and what I've learned from this project. And I wanted to just cry at that point, because that is, like, as a patient, that is so incredibly meaningful. And I thought, like, that's for every patient that this person is seeing for years to come. We heard it a couple of times, that one was really explicit. Like, when I walk in the room, I'm approaching this person differently. And when they mean impacts that we're not capturing, those ones are really important. And we're capturing a lot of process, but it's hard to capture those things. So that was for me, when I think of the project and I think of all the analyzing we did, that's the one that was the most meaningful to me as a patient, to know that somebody who's got such a huge influence on kids' lives has actually learned, is actually interacting in a different way that's so important to those kids. So thanks, Beth. That's getting all emotional again. Okay, last one. Yes, so again, the diversity piece, and I'm sure that a lot of you who are on this call are working really, really hard to work on that. So I'll pause again for you to read what we heard here. Yeah, so there we go. There's the call to do better and to be more inclusive. And that part's really difficult, and it was really important that we hear it and that we try to do a better job by changing the way that we do things. Okay, so that was your sneak preview. So very quickly now, I'm going to go over a couple of reflections. I'm going to do the evaluation process, and Beth is going to do the methods. So there was this team building that occurred throughout the process. So that toolkit, if you happen to use it, it really requires reflection, and you have to listen to each other's perspectives. That in itself is worth a lot. The multi-interest holder evaluation committee, same thing. They went back and forth. They were listening to each other. And our basic premise was that if you have interacted with one of our patient partners, you are eligible to join our evaluation committee, because we didn't want to just speak to patient partners. So we can see they dominated the committee. There was more of them, and Beth showed the numbers. They were very strong in the committee, but there was other representation. And that whole acknowledgement that evaluation is everyone's business and really essential to the network, and that shaped our approach. It's not nice to have, it really need to have, and it really is a concern of everybody. And when we did the evaluation, we found out that people did feel that it was everyone's business. So the analysis, oh my, like I found out then that, yeah, I'm not going to have a second career or third career as a researcher. That was very long. But it was very interesting, and many hours of reflecting on what we heard beyond categorizing it. So it really helped gel us as a team. I think we all learned a lot from that, and that, yeah, it requires more time and budget for sure. You have to budget for it. And that question, as Beth said, we don't know if we have the answer. How do you balance how much time you devote to the evaluation versus doing your high quality engagement? So it's really it's a real head scratcher. Beth?
Thanks, Maureen. So I think one of the things that I think we all felt really grateful that we had chosen to use a mixed methods approach. And I think one recommendation that we would make to others is to do this as well, if you can, because we did learn a lot from the surveys, but we really learned a lot from the in-depth. We got a much more in-depth understanding of the key strengths and limitations of our engagement activities from the interviews, and pulling everything together was really rewarding. So participants revealed the impacts of the involvement on their experiences and on the projects, including some of the challenges in those interviews and focus groups. And that's where some of the some of those more surprising findings came out, and some of the things that led us to reflect on maybe some of the bigger impacts of the work. And so one thing that we wanted to raise again, I think we've talked about this now, but the potential biases due to having Maureen and I conduct the interviews and focus groups. And I would love if people have thoughts about that or want to talk about that in the question and answer period, because we've talked about it quite a bit. And I mean, one of the challenging things is that because we're a research network and we have so many projects on the go, I mean, we kind of went into this thinking like, we'll evaluate the network as a whole and then this one project. What actually happened in these interviews and focus groups is that, of course, people just kind of free flowed back and forth between one project and another and used shorthand. And we felt like it might have been quite difficult to sort of facilitate the conversation if you were somebody who didn't kind of have a really strong understanding of the network and the research activities. So that was part of it. Um, and we do feel that we have a relationship of trust with people and that we've kind of built up and that enabled people to be frank with us. We did get some critical feedback, but at the same time, like if we had had sort of an external facilitator, would we have had more critical feedback than we received? I think that's the kind of concern. So just something to kind of really have some good discussions about if you're planning an evaluation.
Can I just add a piece to that, Beth?
Yeah.
Um, so about that bias, the year before we started, we had for all of our patient partners and youth advisors, we had created this little invitation called "Come and have a chat with Beth and Maureen" individually. So, and we'd done a survey. We had launched a survey, and then we had invited them after the survey, come and chat with us. 20 minutes, sometimes it went half an hour, usually about 20 minutes. And we had an incredibly warm reception to that. People were saying, "Oh, it's so nice to talk to you both." And we heard a lot of really positive comments. And so we kind of thought about that too, because there was a really good response to those chats. And even during the focus groups, there's some of the comments people say, "Well, really happy that we're actually talking to both of you and you're here together." So it was a really hard decision because, if you look at it purely from a scientific, like there's definitely bias. And did people feel comfortable in criticizing us? I like to think that patient partners just want things to improve and that they will try to do their best, but that depends on the person. So, but we had kind of tested it a little bit the year before with but just with our patient partners, and we had multiple times people commented, "I'm just so happy to get on a call with both of you." So that kind of encouraged us to do that, but we know that it's definitely a limitation of our results. Okay. All right. So final reflections on findings. Yeah. Like, what do you do? What about the questions you don't ask us? So how do you incorporate that into your work? And oh, that was a real interesting one. Youth, Beth mentioned the one about the youth, and we were just like trying not to chuckle. But what about the things you think you know, but you don't know? You think you know what you're doing, but you don't know. Like it was very interesting. I think that we learned that for multi-year projects, if you happen to be multi-year, evaluate as you go. So immediately act on what you hear and be accountable for the feedback. So if you can act immediately, that's really good, because there's nothing worse than waiting until it's over and saying, "Well, we should have done this, we should have done that." There are many things that are being said. So we had a lot of feedback on communication. We were able to immediately, we know that people are much more satisfied with that. And this whole good communication was key for everybody who we talked to, whether it was a researcher, an ethicist, or a youth, or they all want good communication. And the message was that we heard from the non-patient partners was like, "Let us decide how much we want," because they're all, I think I said that earlier, but that was just kind of surprising to me. So there was a lot of reflection, but we were able to change our processes immediately and have that accountability to what we heard and improve our practices. And some of the bigger pieces, like the impact, that's just really important to know and to talk about and to communicate that. So that was kind of how we reflected on the findings. And I think we're done. Oh, over to you, Beth. 2 slides left.
Oh, yeah. Last 2 slides. So just an acknowledgement slide. Everyone who, of course, participated in the surveys and interviews and focus groups, but we particularly want to acknowledge our steering committee members and the members of our evaluation committee for this work. as well as our youth advisors. We would really like to acknowledge Dr. Julia Abelson and Laura Tripp from the Engage with Impact Toolkit team. They were just fantastic at answering our questions and supporting us to make the adaptations that we wanted to make. And of course, our funding from CIHR.
And we're just best of luck on your patient engagement evaluation journeys. Feel free to contact us, and we look forward to discussing with you. And there's a link to the casebook that was published, I think, in October, where we have one of the case studies. And I think yesterday, or was it this morning, Beth, we pressed the button on submitting a publication of all of this work. So we're hoping that it will be published, and we will send that to Priscilla once it's published immediately so that she can circulate it, because we've been working pretty hard. And just so that you know, I'm the first author on the publication, which is very exciting. And Beth is the senior author, whatever you call it, at the end there, the one who's responsible for it at the end of the day. But we worked really hard on getting this work published too. And back to our co-design that we worked on a publication together also. So that's it. Thank you.
Thank you so much, Maureen and Beth, for such a wonderful presentation, also for sharing that there is a forthcoming publication, and I'm happy to share with this community of members that publication once it's prepared. I certainly am interested in reading it and learning more about the co-design, the way in which you kind of overlaid and utilize the impact tool in more detail. So at this time, I would like to ask if there are any questions from those on the call. Please feel free to either raise your virtual hand or to add your questions into the chat for our speakers, and I'll make sure to keep an eye on that so I can raise those questions to both of them. Oh, we have our first question in the chat. I'll just read it out for everyone. When you say evaluate as you go, can you describe what you mean by that? How are you doing that as you go evaluation? I think that's a very good question.
Should I try, Beth?
Go for it.
So, for example, if we have a meeting, like, we with our patient partners, we check right away, using a little evaluation, like, how was it? Were you prepared? Like, we do constant, but those are just of those people for that specific activity, right? So it's quite different. So we do evaluate all the way through, and then this one, the network evaluation, is quite different. The questions are quite different, but we're always looking at process. So the evaluate as you go is really our processes, because people want, the move is to focus on the impact, which is really important. But oh boy, you better make sure your processes are good too, that you're treating people properly and that you're creating a meaningful environment. So we also value process evaluation, and we do that like as we go along.
Yeah, and I maybe would just add to that too, like, and perhaps this is something that would be a bit trickier if we'd had an external evaluator support this, although you might still be able to do this. But as we kind of went through the interviews and focus groups, it was apparent pretty early on. A lot of people had ideas for us to improve our communication in the network, like things that people were sort of that we'd been unclear about, or like telling the non-patient investigators and staff more about what was happening with the patient partners and advisors, and just coordinating everything together and giving more kind of updates. And one of the things, like, fairly early, while we were still collecting data, that we started was having just quarterly updates without a specific ask of our patient partner, our adult patient partners and parent advisors, to give them an update all together as a group about kind of everything that was happening, because we could see that was kind of something that that they wanted, and that was a limitation to some of the work that we'd been doing. So that's maybe part of evaluate as you go as well, that like we didn't necessarily wait until we completed all of the formal analysis to start implementing some changes that we could see were going to be coming out of the evaluation.
Thank you so much.
Perfect. I'll give folks, oh, I see we have another question here. Is there also a patient engagement work for children who are in the transition stage, and are or going to see adult medicine doctors to learn about their challenges and to help them.
So Rare Kids Can has a whole committee on that, right, Beth? Like, so under the Rare Kids Can Research Network project, I know there's a committee on transitions, and there's a lot of work on transitions. Our youth advisors, now some of them have kind of reached the maximum because we've had them for a number of years, but when we recruited for youth, we went with pediatric youth, so we went 12 to 18. But if you use a WHO definition of youth, you're going to go to 25, right? So it kind of depends on, like, but they were transitioning, but we've never really focused on that. It's an incredibly important area. If you want to add more to that, but I know that Rare Kids Can has done quite a bit of work in rare disease. Rare disease transition often tends to be even more complex than other areas. But
Yeah, it's a critically important part of
right,
pediatric to adult medicine. It's not a research question like care around transition. That's one of
right.
the kind of it's not a focus of Inform Rare's work per se, but are many of the youth advisors we work with are at that age and are interested in that topic, which is why it was great to see that Rare Kids Can has a whole kind of so Rare Kids Can is a pediatric rare disease clinical trials and treatment network. Can try to find the website and put it in the chat, and they actually have a whole kind of team of people who are interested specifically in transition to adult care in the rare disease population. But yeah, really good question. And certainly our youth are right at the age for that, and some of them have gotten involved.
Fantastic. Now, you were both at the point, as you shared, working towards publishing all of this incredible work you've been involved with from process to impact, which is great. Um, you shed some light on some of those reflections around methods in your slides that may not be the totality of the full picture of what transpired. May have had to hold back on some things. I'm really curious now on the other end of this. If you were to do anything differently, what would that be? And would you interview yourselves, now thinking back, or would you hire an external person to do that for you?
Do you want, I can start, I guess. I don't know, like, doing things differently in terms of the evaluation project. I think I might have, I think if I were doing it again, I would just go in with a better understanding of how long it would take because it took a long time. I think we were really lucky that we were able to simply just spend the time that was required to do it. But it would have been nice for everyone, I'm sure, to know kind of really what we were kind of getting into. I'll try to think about other things that maybe we could do differently. I do think that if I were doing it again, I think I would want to do the interviews again. There's something about being on the calls with people and really hearing from them. It seemed like it was rewarding and meaningful for the participants in the interviews and focus groups, and it was really helpful. I learned just so much from the process of listening that I wouldn't have wanted to miss out on that in terms of being able to kind of make some of those changes. What do you think, Maureen?
I absolutely agree. If I had not heard with my own ears the statement about, I've changed the way I talk to my patients, or I'm engaged now for the first time in my life because you've made it flexible and I can step away and he actually, then Maureen gets on a call and updates me on everything. If I hadn't heard that with my own ears, I don't know what the impact would have been. If I'm having a bad day and I'm thinking, what am I doing here? Those are the things that come to mind. So for myself personally, this is kind of a selfish reason. It was incredibly rich for me, and I learned so much from them. So I would hate to lose that piece, and well, I'm sacrificing limitations. Yeah, okay. But to me, it was really like on a personal level, it was really important. And we heard repeatedly, like, we're so happy to be talking to both of you. This is great. This is what leadership looks like, and this is what co-leadership looks like. Like we're actually modeling it, right? So I think yeah. I wouldn't do it. I think it was very long. One thing I wanted to say was, if you're sitting there, you're thinking, there's no way I can do this. I don't have that kind of time period. The impact trials, what do they call it? God, Chelsea's not here. Oh, Jody's here. Impact Trials not network, whatever. They're a training platform, and they have all these fellowships. We just did one with the Engagement Impact Toolkit, which we're going to try to write up soon, in 1 year. So a much shorter project, much more focused, and we did it using the toolkit in a year. So we're showing you a longer one, but it can be done with a much shorter project too. Jody's put the name of it, Jody, in the chat, because I know I messed all that up, but it can be used for different lengths. We're showing you a long one, but it can, and if you read the case book, there's other groups that have used it, and you can do it in a shorter. You just have to really narrow your scope. Like, you've got to really say, this is what I want to evaluate, and only that. And then you can do it in a shorter time period. So don't be afraid.
I think those are great lasting words. I do want to add one additional question because this one's been burning for me, and perhaps it's on the minds of others on this call. It's with respect to how you selected using the PEAT as well as the Engage with Impact tool. There are other evaluation tools that are out there that have, been rigorously tested, that are evidence-based. How did your team land on those specific evaluation tools to be used in this project?
I can start briefly. So the PPEAT is linked to the Engagement Impact too, so they'll actually tell you where you can find the question. And because we had a bit of a relationship with adapting it, we were able to just get on a call with the people from and say, okay, we want to use your validated tool. This is what we're thinking that we're going to adapt. And yeah, go ahead. That looks great. It's still validated. So we looked at other ones and it just didn't fit. And we had that connection that we could say, we don't want to lose the fact that it's validated, but we don't want to ask questions that don't apply. So I think it was, for us, it was kind of like a package.
I would agree. And Maureen was involved in the co-development of the Engage with Impact Toolkit. And so she really brought that to the table. And I think that was a big reason for selecting it. And then you already knew the team, I think, Maureen. I didn't know them as well as I do now, but but they were extremely helpful and supportive and flexible, which is really difficult when you're trying to look at a tool that's been well developed. And I think you're right, there's other ones out there, but then not all the questions apply, or you kind of want to adapt the wording because you're doing something a little bit different. And being able to kind of reach out and get support with what we can change, what they would rather us not change, how is that going to look, was a big factor for us.
That's perfect. Well, this brings us to time. Thank you so much for joining us today and sharing a little bit about the incredible work that you're leading in the space of evaluation. I certainly am looking forward to your publication once it's available to read online. And thank you to those who joined us on the call today. In the chat, we have a link out to our next community engagement series event, which will be held on February the 19th, titled Implementation Science 101. What is it and how can I use it? Hopefully, I'll see some of you on that particular webinar as well. But I'd like to thank you all for joining and certainly look forward to seeing you at a future event. Have a good day.